Welcome everyone to our workshop today on ultrasound-guided cannulation. My name's Amy, I'm an emergency doctor and I'm going to be taking you through the workshop today in conjunction with a couple of the other doctors here. So we've been running these workshops for approximately 3 years now and have trained over 700 clinicians within our health service. So what we're going to do today is essentially has 3 components. So first component, we're going to start with a brief lecture on ultrasound-guided cannulation, and we're going to cover some theory around that as well as some very basic physics. The second component, we're going to break into pairs and do some vein mapping or practice finding suitable veins on each other. And the third component will be practicing ultrasound-guided cannulation using the chicken models that we've prepared. Okay, so what we're going to cover in the lecture. So we're going to talk about when to use ultrasound to guide cannulation, some very basic principles around the ultrasound, how to set up and prepare for ultrasound-guided cannulation, how to choose an appropriate vein, and protocols for needling, which include both in-plane and out-of-plane techniques. So when to use the ultrasound. So there's a few groups of patients where it can be difficult to cannulate and where we should be considering using ultrasound early. This includes extremes of age, both overweight as well as underweight patients, chronic disease, IVDU or frequent blood samples, dehydration, upper limb swelling and scarring, previous history of difficult IV access, and no vein seen or palpable. And it's really those last 2 that are the most important. And if we look at recent studies that consider predictors for difficult IV access, the 2 best predictors for difficult access are a previous history of being difficult and no vein seen or palpable, which I think makes sense. But make your first attempt your best attempt. So this is the message we're really trying to promote by running these sessions. So it shouldn't be that you have 3 goes before you ask for help. If someone comes in and they have a few of those predictors of being difficult and they tell you that they're always difficult and they always need 4 or 5 goes, then we should be getting the ultrasound early and using it on the first attempt for that patient. So now for some very basic principles about using ultrasound. So essentially the transducer emits sound waves that enter the body, hit a structure, and then are reflected back to the transducer to form an image. Essentially, the larger the reflection is, the stronger the signal, and therefore brighter and more clearer the image is. So you want to be right on top of the structure of interest. It's also important to remember that the beam of sound waves emitted is actually only as thin as a credit card slice. So although the transducer is quite thick, about 2 to 3 centimetres, it's really only like a credit card thin slice. And this is really important when you start moving the ultrasound probe on your patient's arm, in that very small movements can cause quite big differences in your picture. So when we're going to use ultrasound, we need to consider our 4 Ps when we're setting up. And these are patient, position, probe, and preset. So patient, make sure you have the right patient and that they're informed about what is happening. Position refers to both yours and the patient's position. So you want the ultrasound machine to be sitting in front of you so that you don't have to twist around to try and look at the picture while you're trying to cannulate. You want to have your elbows supported, and you should use your dominant hand for needling. So most people will scan first with their dominant hand, and then just before needling might change to their non-dominant hand. The last 2 Ps are probe and preset. So we want to use a linear probe, which is a high frequency probe. And you need to make sure you check the orientation of your probe. So most probes will have a little marker on one side, which correlates to the marker on the screen. So check that before you scan, but also just use your finger just to touch the top of the probe and see which side of the screen moves. Essentially, you want the left side of the probe to correlate to the left side of the screen. And this just helps to keep you oriented when you're trying to cannulate. The aim should be for this to be a sterile procedure to keep any risk of iatrogenic infection or contamination as low as possible. So you should wear sterile gloves, and you need to use a sterile freezer bag over the top of the probe. So you put some ultrasound gel on first, sterile bag over the top, and then some sterile gel on top. And we'll demonstrate this when we do the vein mapping. Before you cannulate, you're going to clean the skin, so wipe away the gel, and then use an alcohol swab like you normally would. After you have cannulated, make sure you clean the probe properly using toughy wipes. Okay, so once you're all set up, you then need to choose an appropriate vein to cannulate. So we need to think about how we can differentiate an artery from a vein. And there's a few things we look at. So firstly, arteries should be pulsatile. Veins will not be pulsatile and they'll be collapsible. So with a bit of light pressure with using your ultrasound probe, a vein should collapse. Just remember that a vein that has a thrombus within it won't collapse, but is also not a suitable vein to cannulate because it won't accept a cannula. You can also use colour or Doppler to confirm flow within your vessel. And we'll look at this when we break up and do some vein mapping shortly. Just be mindful in particularly hypotensive or hypovolemic patients, the brachial artery may not pulse and it might be compressible with some firm pressure. So I think it is a really good habit just to find your brachial artery first so you know where it is and then go looking for veins. So what I like to do is start in the cubital fossa. You can see the bone sort of deep or in the far field of your image and then find that brachial artery. It should be roughly in the centre. Once you've found that artery, you scan medial, lateral, up and down until you find a vein. And pretty much any other anechoic or black circle should be a vein. You want to make sure you visualise a couple of centimetres of the vein, so sort of up and down. Make sure there's no branches, no thrombus within it, and make sure it will accept a cannula. My go-to veins, if I can't find anything, are the deep brachial veins or the basilic vein, and we'll have a look at these when we do our vein mapping. When you find a suitable vein, you just need to optimise your image as well, and we talk about depth, focus and TGC. So on your machine, the most important thing really is depth, just to make sure that the vessel you're interested in is right in the centre of the screen. So this is just a picture looking at arteries and veins. So the image on the left has no pressure applied, the image on the right has some pressure applied, and you can see that the vein has collapsed. And similarly, just a little video showing the same thing. So you've got an artery pulsing down here and a vein up there that collapses with pressure. Okay, so now we've set up and we've chosen our appropriate vein. It's now time to cannulate. We can use either the in-plane or the out-of-plane technique. So with the in-plane technique, the transducer runs along the long axis of the vessel. The benefits of this technique are that you visualise the whole length of the needle as it's inserted. It's also useful when the artery sits just underneath the vein. The downsides are that this can be quite challenging to get a nice view of the length of a vessel, especially when holding the transducer in your non-dominant hand. And you'll see how tricky this is when we get to practice vein mapping on each other. The trick with this technique is once you've found a perfect view of the vessel with the ultrasound, don't move your transducer. It needs to stay very still. The only thing that moves is the needle. As you advance your needle, you should see it clearly on the screen. If you lose it, you stop advancing and fan the needle slowly from one side to the other until you see the tip of the needle again. Then continue to advance. This is just a video demonstrating the long axis or the in-plane technique. So you can see we've got a long axis view of the vessel there and the needle coming in. We lose the needle tip, so we stop, we fan one way to the other till we see it again and continue to insert the needle. Lose it again, fan from one side to the other. And you continue to do that until the needle is within the vein. You can then rotate it back to short axis just to confirm your position. So the next technique we'll talk about is the out-of-plane technique. This is essentially where the transducer runs along the short axis of the target vessel. This is probably the more commonly used technique as it's easier to get this view of the vein. It's also good if the artery lies next to the vein. The trick to this technique can be remembered as follow the leader. Once you insert the needle into the skin, look up at the screen and find the tip of the needle. Stop advancing the needle and slide the transducer away until you no longer see the needle. Then stop and advance the needle slightly until you see the tip again. Stop again, slide the transducer forward, and continue to do that until the needle has entered the vein. This way, your needle is following the transducer, hence the term follow the leader. This allows you to visualise the tissue before you put the needle through it, And also ensure you don't get confused between the tip and shaft of the needle, which can look very similar. And this is a video of the out of plane technique. So we can see the short axis of the vessel here with the needle coming in. So we stop, slide the transducer away, then the needle comes in, slide the transducer away. So we do offer credentialing from the workshop. So within the next 12 months, if you can get 3 ultrasound-guided cannulations signed off by someone who's competent in performing it, and leave the form on Dr. Watkins' desk, you can receive a certificate. And we just thank EMF for the funding to allow these workshops to take place. And remember, make your first attempt your best attempt. So now we're going to break up into pairs and practice vein mapping. So the first step is obviously setting up, so making sure you know how to turn on your ultrasound machine, and thinking about your 4 Ps, which is going to be your patient, which Stuart here, your position in terms of making sure your elbows are well supported and you can see your ultrasound machine easily. Making sure you select the correct probe, which in this case we're going to use a linear probe, and ensuring your machine is on an appropriate preset such as vascular or vein, which this machine is set up. So then once you're ready to go, you can start scanning. So what we'll do, we'll put a bit of ultrasound gel on first. And remember, as we said earlier, we just need to make sure we cover our probe. So we have a lot of these sterile sandwich bags here. And this works well to cover up your probe, so I'll just pop it on the top. Just like you would for a central line. Making sure there's no air bubbles between your bag and your ultrasound gel. And a bit more gel on the top. And now you're ready to start scanning. All right, so now we're ready to scan. So we'd place the tourniquet around the patient's arm like you normally would, which we've done there. And most people choose to use their dominant hand to hold the transducer initially, and I think when you're just starting, that's the most sensible thing to do. So I'm right-handed, so I'll hold it with my right hand. And as I said before, it's important to make sure your elbows are supported and hold the ultrasound probe nice and low and rest your wrist on the patient's arm so you're well supported. So my practice is I like to try and find the brachial artery first, and you can do that just by palpation. Once you've found it, then pop your probe right on top of that area and see if you can find the brachial artery on your screen. And if we look at our ultrasound machine there, we can see some bones at the back there, which is your cubital fossa, which I like to keep in the background. And we can see right in the centre of the screen is the brachial artery. We can see if we put a little bit of pressure on, you can see that that's pulsing away there. Okay, so as we talked about in the lecture, the things that differentiate our artery and vein is the artery should pulse, and with a bit of pressure it won't collapse, or shouldn't collapse fully. We can see it pulsing there. So once you've found the brachial artery, you know what to avoid. And from there, I just scan medial, lateral, up and down, and try and find something that looks like a vein. And essentially, any of the other anechoic or black circles that we see on our screen should be veins. So we find one right in the centre there, and if we put a bit of pressure, completely collapses. Okay, so that's a vein. The other thing we can do is pop a bit of colour on, or Doppler flow. So we'll make that work. So we go back to our artery. We can see that pulsing away. If we go over to our vein, not really pulsing. And Stuart, can you wiggle your fingers for me? You can see a bit of flow then, and relax. Thank you. So we're happy that that's a vein. Okay. So now the ideal depth sort of for cannulating a vein under ultrasound is about 0.5 centimetre, and we look at our centimetre indicators on the side there. So this vein and screen's probably a bit too superficial really, because by the time we see the needle, we'll either be in the vein or out the back. So you want to find something a little bit deeper if we're going to be using ultrasound. So there's another vein there, and again, a bit of pressure to prove it, and collapses. Again, it's probably a little bit superficial. So I'd keep looking around for something else. probably that one there, I think looks pretty good. So if we put that right in the center of our screen, and just remembering to think about our depth, focus and TGC and make sure we're optimizing our image. I think that looks pretty good. And we can see that that's just over 1/2 centimetre deep. Bit of pressure on there, completely collapses. So we're happy there's no thrombus in there. And if we follow this vein a little bit distal, we can see that it bifurcates. And that's really important because we want to know where we put our cannula in. We want to make sure that the cannula will be able to advance. If we go a little bit proximal, we can see there's a nice straight section of vein there, which would take a cannula quite well. So that would be my choice. My go-to vein, so if you can't find anything when you're having a look, I always have a look for deep brachial veins, which are 2 little ones that sit either side of your brachial artery, which in Stuart's arm are not particularly prominent, so they probably wouldn't be great ones to go for. And the basilic vein, which is the one we hadn't screened before. So that's that one there, just in the medial part of the lower arm. So the reason they're quite good is that you can't really see or feel them, so people haven't ever really used them before if they haven't had ultrasound-guided cannulation before. So as we talked about in the lecture, the 2 options you can use to put a cannula in is the in-plane or out-of-plane. So if we were going to do out-of-plane, this is entirely appropriate and ready to go. We can see there's a nice section we'd use. If we're going to use in-plane though, we'd have to rotate our probe to get the longitudinal view of the vein. And as we said before, this can be quite tricky, and we sort of recommend a 2-handed approach if you're going to do that. Can you rotate your arm anymore? It's a bit of a tricky position for the patient. I'm going to rotate into long, so 2 hands. And just try and open it up like that. So you can see there we've got a longitudinal view of the vein, and it's very tricky to get in screen there. Can't do it. Non-lock hand's good. Open it up. That's probably about the whole length we're going to get of it. You can see in the screen there we've got a nice longitudinal section of vein that we could do for in-plane. So now we're ready to place the cannula under ultrasound guidance. So I've got my sterile gloves on. I've got our probe covered with a sterile probe cover, and we're going to use sterile ultrasound gel. Now we're going to practice the ultrasound-guided cannulation using these chicken models. So these are essentially just chicken breasts as bought from any butcher or grocery store, with 2 balloons, like long balloons inside them that are filled with red food colouring. They do actually feel quite lifelike when you're cannulating, so they're very useful to practice on. Just be mindful that the red food colouring will stain your clothes, so you should be wearing gloves and a gown to protect your clothing. So as before, we want to protect our probe, so we need to cover our probe again with sterile freezer bag and sterile gel, and I'm wearing sterile gloves again. And we're going to practice both in-plane and out-of-plane techniques. Okay, so just having a look, obviously we've got a blue balloon and a red balloon, just purely made as a vein versus an artery. And if you want to make one of them pulse, you can just press the balloon to get that sort of pulsing look on the screen. So we're going to be targeting the blue balloon today, and we're going to start with the out-of-plane technique. So I'm going to press the centerline button just to find the centerline on the screen. And I'll line it up. And remember, when we do the out-of-plane technique, we do the follow the leader type approach, okay? So we want to get our target right in the center, which we're happy with. And remember, on a real person, you'd have to wipe away the excess gel as well as use an alcohol wipe before you do this. We get our needle nice and close to the skin or chicken, pierce through the skin, and then look up at the screen. And you can see a bright white needle there, so we're going to stop, advance our transducer, or slide it away, advance our needle, stop, transducer away, needle, so we're always just following our transducer, okay? And we can see there that we've got flashback into our cannula there, so we know that we're in the vein. Now in these you can advance the cannula as you normally would if you like. We're pretty happy that we're in the vein there. Okay, so that's the out of plane technique. And I'll now demonstrate in plane so we can get rid of our centre line because we don't need that anymore. So same technique as before, we get our balloon or vein right in the centre. Two-handed technique to try and rotate and get it in a long axis. So we can see, and this is quite tricky as we mentioned before, especially when you then have to hold it in your non-dominant hand to try and prevent it slipping. But that's the picture you want. You want the black or anechoic lumen with bright white walls. And as I mentioned before, the trick to this technique is once you've got that nice view of your vein, is don't move your transducer. Okay, so we want to keep that really still. Now it doesn't matter which way your marker goes on your probe as long as you know. Okay, so I've got the marker end facing towards me, which means as I needle, the needle will appear on the left side of the screen. So it doesn't matter which way you do it as long as you know which side to expect your needle. Okay, so again we go nice and close to the transducer, through the skin. We can see a bit of movement there. If we don't have a nice crisp needle, we can stop, fan the needle till we see it nice and clearly, and advance the needle some more. We lose it, we stop, fan the needle. So always remembering to keep that transducer hand really still and just fan with the needle. And there we go. So you can see quite clearly there on the screen that we've got a needle in the vein. You can always rotate back into short or in the short axis just to prove where you are as well if you want. But that's it, they're the two techniques. So we'll get you to practice both techniques multiple times and we'll come around and give you a hand as you need. Make sure when you're finished that you put your sharps in the sharps bin. We put all our chicken breasts and materials in the clinical waste bin. Remove your sterile probe and make sure you clean your ultrasound probe well with a toughy wipe just to prevent any staining to it.